Okay, it's 12 o'clock, so I know a lot of people have planes to catch, so we're just going to get going. Welcome to the Radiation Oncology Research Support Committee. So this is the agenda is in two parts. We're going to have a welcome from Dr. Kachnik, an executive summary, and then we're going to have a keynote. Dr. Anna Case, who's remote, will have a 20-minute keynote on radiopharma. Then we're going to have two developing studies. Dr. Arya Amini and Dr. Henry Park both have studies they'd like to get feedback on. And then we'll go quickly through the Disease Liaison Committee reports. All of the slides are uploaded, so we should be good to go. So without further ado, Dr. Kachnik.
Do we have folks on Zoom too?
We do have folks on
Okay.
Zoom.
Oh, for the folks on Zoom, can you all hear us and see the slides?
Yes, we can.
Yep.
Thank you.
Yes.
All right, so welcome. I think since I'm a rat-on, like all of you, you know my role, but you probably know all of the things I'm going to present, except maybe the last slide. But maybe after the plenary sessions, you know all this stuff too. So you've seen this slide before, but it's more of a reminder that we serve a very important role here at SWOG. We not only provide support for radiation when it's on trials here, but we also have opportunities to be PIs of the trials, as well as to do secondary analyses. And I think we don't do a good job at mining the data. There's lots of things we could do together to mine what we have available and answer really important questions that may actually inform us on developing new trials. So I think you've seen from Dr. Yu that we've put sort of a mini RFA call for a concept from radiation oncology to move forth. There's a couple different avenues to do this, and maybe this might even open up other opportunities for us. So one is, Dr. Blanky said that each of these groups can put one trial forward, and Dana Sparks is our kind of point person at headquarters for that. But Dr. Kathy Albane has done a really good job building up, I would say for us that know NRG, kind of akin to the foundations, like the RTOG Foundation that does their own trials. So in SWOG, it's called CTP or Clinical Trial Program. So it's SWOG CTP. And it's really very new, but they already have about 6 trials in the making that are moving along pretty rapidly. And I think that's another mechanism for us to consider if, and we know that many of us have trials pitched in the disease sites, but maybe they aren't high up in priority. So this might be something to consider, especially when it's something that leverages pharma. You know, if there's a drug or if it incorporates ctNA or something like that. So think about that too. You know, we'll determine which of the trials that you submitted to us we'll put forth to our own trial moving forward. But I think for the others, if there's a CTP way, we can speak to Dr. Albane about that. Oh yeah, that's actually easier, James, thanks. Do we have any new members? I know, you know, we're only hybrid. Usually we're about 40. Oh, hello. So nice to meet you too. Maybe I'll send around a kind of sign in for the live people. But I just wanted to mention there's travel grants. So especially for new folks or for us old folks that want to bring new folks to the meeting, I think we have a lot of opportunities thanks to the Hope Foundation that we don't use. And one of them is the travel grant. So if you have junior investigators you want to bring, or if you need to think about applying for a travel grant in the future, please do. All right, next slide. Oh, sorry. I guess I could do it myself. I'm so sorry. We were in one room yesterday that like this thing just didn't work, so I think I gave up. So if you went to the plenaries, you heard about some of this, and there's even actually some other ones that I don't have on here. But the Hope Foundation offers a lot of funding opportunities, and it's not just to us. They're open up to, folks that are in Alliance or ECOG or Energy. So the good thing is the ends are always really low on these, meaning if you apply, you're probably up against 6 others and not more than that. So any ideas are good ideas. So the first thing is a grant writing workshop. It's virtual. You still have to apply. The applications due May 1st, but it's, if you apply, I'm certain you will get into it. On to the right are NCORE pilot grants. NRG actually does a really good job at this, but now SWOG is doing it as well. Does everyone know what an NCORE is? I never did, but is it worth explaining, or do folks really explain? Okay, so in every of the 4 adult cooperative groups, there's 2 grants. So there's a grant for the disease site trials. That's called the CTEP grant from the NCI. And there's a grant for all of the more community-based trials, so cancer prevention, cancer control, which is symptom management, survivorship, cancer care delivery, which is usually kind of feasibility of doing things in the community that are cancer management related. That sits on another grant called, it used to be called CCOP, but now NCORE, which is just a fancy name for the Community Oncology Program from the NCI. So there are 50K NCORE pilot grants available. Again, these are very few page grant applications, but if you have any idea that sort of falls into cancer prevention or symptom management, or something where the primary outcome's a patient-reported outcome, or things that might lead to a symptom management type trial. Maybe it's like you're looking at biomarkers of fatigue, or, it's pretty wide open. So if anyone has any ideas and they want to even just run them by us, please do, because again, this is due June 1st, but it's low-hanging fruit. Never. Because I'm the one that reviews them. They often ask me to review my own. I'm honest, though. I say no. If you guys went to plenary, you could see all that Columbia got, and it's mostly because it's Don Hirschman telling people. It's just saying, look, apply. No one applies, apply. So we should take advantage of these things. And again, if not you in the room or virtually, let your colleagues know. We can send this slide around, or just go to the Hope Foundation website. And then just like that 50K, there's a Hope Foundation seed grant that's coming up July 1st. Also a very short application. And this is sort of anything. It could be money to do like a correlative of an existing trial. It probably could be money to do a bigger secondary analysis that needs more than stats. It could be doing some lab stuff that might inform a future trial question. It's pretty wide open.
The impact and the specificity for SWOGs, they use the name protocol number.
Yeah, it's all the grantmanship, how you utilize SWOG and inform a future, question is usually what gets you the money. And then there's a bigger award. There's more, but these are the ones that are due in the next few months. The Hope Foundation Impact.
Okay. Treatment planning. We have papers in SWOG.
Yeah.
I'm sorry to cut in, but
No, it's okay.
The treatment planning thing, we've had papers in SWOG, and you wrote it showing that if you don't treat patients directly, you don't get a good result, right? And so, a good paper to describe how we think we should be doing SBFD.
If you want the people on the other end to hear you, you're going to have to use the mic.
Oh, it's a good point. Thank you I should have realized after 3 days of this.
So right now.
Sorry, virtual Zoom people.
So just for the virtual people, I was just commenting that for these grants, that they rarely get more than half a dozen for each category. And so we have had radiation oncologists get them. And they've been studies on why some people might not want to get radiation. There have been things on dosimetry and doing better checking the dosimetry on a past study and writing a paper on it, or writing standards for example, SBRT, if we want to have different standards than other groups. As you know, there was a lot of discussion of different radiation approaches for SBRT, and they wanted to make it fairly laissez-faire. And, you know, we may have a simpler way to describe it than is often very hard to do from what you get from NRG, as they have all those committees that all write things that are not necessarily compatible or, right.
I know David Horowitz and one of the surgeons from the surgical committee just looked at our cholangio and gallbladder trial that we did about almost 10 years ago to answer a lot of secondary analyses questions. But David had an idea to, you know, it looked like while we had an atlas to do this 10 years ago, the atlas probably doesn't make much sense in more modern times. So I mean, David, maybe that can even be one of these. It's worth filling out a few pages. So the next one is the Impact Award, and that's actually a pretty big money one. It's $250K, so that you can pay down some of your salary to give you more time to do things. And that's, again, it could be, we've had folks in the radiation committee, many folks that have gotten this award over the past couple years. You know, it could be translational stuff that might lead to a clinical trial. It could be patient-reported outcome stuff that might lead to a clinical trial. These things are usually pretty wide open, but it's all about grantsmanship, so strong letters of support and how it would inform something down the line for SWOG are the two components for all of these things. And there's another one that comes right after these in the summer, I think August. I didn't put on the slide because it's not developed yet. But if folks have VA partners, it's going to be for a VA. But we can talk about that in one of our upcoming meetings. So some recent news, but it might not be. It was recent on Wednesday when I started here, but maybe not anymore. So when I was flying in, I noticed on Twitter that our NCI cancer leader stepped down, and he was really good to us in radiation, but also to our cooperative groups, including SWOG. The good news is the associate director is taking over for now, Dr. Lowry, and he's been really good too. But just he's been there. And then I think now you know from plenary, but next year at this time we'll have group chair elections, so that'll be more important and some of you might be the kind of SWOG PI at your institution, because you'll be voting for the person. So if you have any candidates to nominate, you can actually reach out to Mike LeBlanc, who's our group statistician head. So, and if you need his address, just ask us. And then I think while we don't really have one yet for our support groups, I did mention to that, hopefully after this meeting we can figure that out. I hope that folks have noticed we're trying to also move towards improved DEI here at SWOG. So if when you were, or you'll still be, I guess they're done now, the disease site committees, they already have DEI liaisons. There's a new DEI committee, a new DEI vice chair position that they're trying to hire for, if you know anybody that's interested. That's also on the website. And I think we're just trying to really rev it up, not just from having liaisons, but how we look as a group, how our leadership looks, but also importantly, really making a better effort on our clinical trial enrollment. And that's not just for SWOG, like all the cooperative groups are really working towards that right now, led by the NCI, who's putting in a big effort towards this too. Yeah, I don't know if you've had to do it. I've had to do it already. Formal leadership training. We've had, for the past year, I think I've had many hours just SWOG-specific DEI training, and that will sort of go through all of leadership and likely then down through membership. I know,
Yeah, I was just
Dr.
gonna-
Akuniev.
Yeah, we've all, I think most of us have taken the DEI training, and then we didn't do it here. I rarely saw a single protocol that got presented where they talked about, and by the way, this meets the criteria or it has weaknesses or whatever it is. Like, for example, a lot of the biomarker studies aren't really for blacks because they have different SNPs, and so they can't possibly have the same. There are lots of things like that we need to talk a little bit more about. So I'm just going to suggest to this group, when you write a protocol, when you present it, if you start talking about it, everybody will go, cool, right? Because you're actually thinking about it. And it really was supposed to be in every protocol, so every concept should have had a word about it, but it hasn't yet.
It's funny, I at Energy Oncology, I live on the NCORE side of the house, and that's, probably priority 1, 2, and 3 on every trial design, from eligibility to recruitment strategies. But it is interesting how it sits more in NCORE's primary thought, but not for the disease site groups. And I don't know, I know David was, but I don't know if anyone else was in GI yesterday. And it ended on a very sobering presentation or comments from our new DEI representative, who he sort of concluded his remarks with, and I was at the closed session this morning and I did not hear DEI or diversity mentioned once. And he was correct. And I just went, we need to do a better job. So good point. I think when we present trials, we should, think about not copying and pasting on eligibility and making it so it's more real world for enrollment. But I also think we need to make sure for investigators, these are things like I do in NCORE all the time. And again, we need to do a better job here and at disease sites. But, the investigator group, we should make sure it's real world and diverse. And then for patient enrollment strategies. All right, any other questions? We'll send that HOPE information around, but please visit that website too. All right, thanks. Oh, no.
Everyone stand up.
Cartoon.
All right. Oop. This is what I'm. Okay. No chat questions. Nope. All right, so Dr. Keith, the next presentation is our keynote.
Great, just let me know when you can see my slides.
We can go right ahead.
Okay, thanks so much for inviting me. I wish I could be there in person with you today, but I'm glad to have this chance to talk about some of the exciting opportunities for clinical trials in radiopharmaceutical therapies and how the SWOG radiation group might engage with this, and also bring up some of the challenges of these clinical trials. So these are my industrial investigator funds, and I will be discussing, of course, investigational uses of RPTs. This is an outline of the different opportunities I'll touch on, as well as
your slides aren't advancing. I think we're seeing a different screen than the one that you're advancing.
Okay, let me just reshare. Hold on just a moment. Okay, is it advancing now?
Yes.
Great, thank you for letting me know. So this is an overview of the different opportunities and challenges that I would like to touch on in today's presentation. Obviously, the greatest opportunity for radiopharmaceutical therapies is that they have been very effective clinically, and we've had 3 major FDA approvals in the past decade for radiopharmaceutical therapies. The first in 2013 of radium-223 for symptomatic bone metastatic castrate-resistant prostate cancer based on this ALSYMPCA trial. showing an overall survival benefit of 14.9 months versus 11.3 months. And this is given as a simple IV injection once a month for 6 months. The second FDA approval was of lutetium dotatate for advanced neuroendocrine gut cancers. It's a somatostatin receptor targeted agent, and this was based on the NETTER-1 trial, showing an incredible improvement in progression-free survival in this patient population, 8.4 months to 40 months. This is a more complex infusion over usually 4 hours per patient with a pre-infusion of peptides for protection, and is given in 4 cycles every 8 weeks. And then just in the past 2 weeks, there was FDA approval of lutetium PSMA-617 for metastatic castrate-resistant prostate cancer patients who've had prior taxane therapy, based on the VISION trial, showing an overall survival improvement from 11.3 months to 15.3 months compared to standard of care alone. And one really striking thing about all of these agents is their relatively mild toxicity in comparison with many traditional chemotherapies and other systemic therapy agents for advanced metastatic cancers. There's a great review article by George Skoros that I would love to point you all to from Nature Reviews 2020, showing, highlighting many of the new agents that are in development, some of them targeting the same targets like PSMA, but with a different radioligand or different radionuclide, and others targeting new targets like mesothelin or HER2. There are many different disease sites represented in the agents that are in development. This graph shows the number of publications per year investigating new radiopharmaceuticals according to disease site. And you can see there's many publications in prostate, but also in breast, thyroid is mostly radioactive iodine, colorectal, hepatic, and there's some pan-cancer targets. There's platforms that use the same radioligand construct, especially for antibody conjugates, and use different targets. So the most widely known one is the Bayer thorium targeted antibody conjugate platform, and they have multiple different phase 1 and 2 trials open with different agents in this platform. And I want to highlight the broad range of opportunities for new clinical trials in this area, and particularly for the SWOG radiation group. I think what's very interesting are opportunities to investigate existing FDA-approved drugs in earlier line or earlier stage indications, or new disease indications, or combination therapies. And I also want to emphasize the importance of personalized dosimetry or incorporating dosimetry for research objectives in their trials, and including biomarkers, and the potential to also investigate new agents. So this is a very busy slide, but I just highlighted in the prostate cancer arena alone, the many ongoing trials for earlier line or earlier stage indications with radiopharmaceutical therapies. So there's 3 large trials ongoing for chemo-naive metastatic castrate-resistant prostate cancer. The SPLASH trial, which is randomized versus abiraterone or enzalutamide, PSMA-4 versus AR-directed therapy, and ENZA-P, which is enzalutamide plus or minus lutetium PSMA-617. This is just a sampling of different trials, obviously not comprehensive. In the metastatic hormone-sensitive population, there's PSMA addition, which is versus standard of care. In the oligometastatic or biochemically recurrent hormone-sensitive prostate cancer arena, we have open at Hopkins the RAVENS trial, which is SBRT plus or minus radium-223 for oligometastatic hormone-sensitive prostate cancer. There's a pilot study of SBRT plus lutetium PSMA-617 open at MSK, and we have planned and approved a trial to open hopefully later this year for a randomized phase 2 of SBRT plus or minus lutetium PSMA-617 at Hopkins and Mayo. And then there is, in the biochemically recurrent setting, lutetium PSMA-617 versus deferred ADT, the Bullseye study in Europe, and radium for biochemically recurrent prostate cancer as well. And even earlier stage for locally regionally advanced or high-risk prostate cancer, there's a lutectomy trial, which is for neoadjuvant lutetium PSMA prior to prostatectomy, and the ProCure, which is a pilot study of EBRT plus lutetium PSMA for node-positive prostate cancer. So just in the prostate cancer arena alone, you can see sort of the breadth of opportunities available. There's many trials investigating new disease indications. So the somatostatin receptor positive diseases are being investigated with lutetium dotatate for breast and HCC, meningioma, pheochromocytoma, and paraganglioma, and PAN, like a bucket trial, is open for all SSR positive as well. And then there's studies of radium-223 in many other cancers besides prostate that have bone metastases. And we have opening at Hopkins a study of lutetium PSMA 617, or sorry, lutetium 0.2002 in adenoid cystic cancer, along with Stanford. And there's also new agents, as I mentioned in the prior study, there's many new agents in development. There's a lot of PSMA targeted agents, including alpha emitters, that are under investigation. One of the most exciting arenas is the opportunity for personalized dosimetry that I'll touch on in a few minutes as well, but you can prescribe to absorb dose and often can use the normal tissue tolerance limits to dose escalate, and there's an ongoing study of lutetium dotatate doing just that. And there's also investigations of biomarkers in DNA repair pathways that are underway. Under the combination therapies, the most common combination therapies that are currently under investigation include immune checkpoint inhibitors, PARP inhibitors, and there's interesting translational research ongoing as well as a PO1 investigating the relationship between immune checkpoint inhibitors and radioligand therapies. I wanted to highlight the CTEP initiative, Radiopharmaceutical Development Initiative, obviously because SWOG is one of the NCI networks that can take advantage of this initiative. And the goal of this initiative is to support investigations of radiopharmaceutical therapies in high priority areas and to support dosimetry and radiobiology being done as a part of these trials. And these are a sample of the ongoing trials that are supported by this radiopharmaceutical development initiative. I did do a search of the current SWOG trials that are investigating radiopharmaceuticals, and it appears that there's only one that's open right now, which is a phase 2 randomized trial of radium-223 and cabozantinib, the Radical study in advanced renal cell carcinoma with bone metastases. But I do want to highlight there's many opportunities for new concepts in this area, and particularly from the radiation group, I think it would be interesting to consider combination trials with external beam radiotherapy or stereotactic radiotherapy for earlier stage and line indications, or for more rare disease groups, different areas especially that may not have as much industry support due to commercial limitations. I want to highlight the very unique opportunities with the radiopharmaceutical trials in terms of imaging and dosimetry. So typically there's a paired PET agent that is used for patient selection with these agents and can also be used for response assessment and quantitative imaging and lesion by lesion analysis. Dosimetry is usually performed with serial SPECT scans or planar gamma scans and can be used to evaluate and predict toxicity or tumor dose response, and like I mentioned, to potentially in the future personalize dosimetry. And you can do interesting investigations of fractionation, dose escalation, radiobiologic effect, or dose distribution using dosimetry. So I highly encourage that to be incorporated into any trial proposals. This is an example of a good dosimetry study of PSMA 617 from Australia. They performed serial lutetium PSMA 617 SPECT CT. So here's an example showing the 4-hour, 24-hour, 96-hour time point of quantitative SPECT imaging in a given patient. And then they actually did partitioned out all of the bone metastases so they could get tumor dosimetry as well. And essentially, you can get dose maps of the dose rate in each voxel and then integrate that over time to get absorbed dose in each region of interest. And they found, not surprisingly, a dose response in the tumor. So the tumor dose is on the y-axis here and PSA response on the x-axis. And you can see the patients that had a PSA response after 12 weeks of therapy had a higher absorbed dose to tumor than the patients who did not have a PSA response. They also, interestingly, saw that patients who had a higher volume of disease of metastatic burden had lower dose to the parotid glands as well as the kidney. So this leads to the potential to select patients for dose escalation or altered fractionation based on volume of disease or personalized dosimetry. And this leads me to talking about treatment planning. So the current prescriptions for the approved radiopharmaceutical therapies, the recently approved ones, are based on fixed activity like lutetium dotatate or lutetium PSMA 617, or weight-based activity, which is how radium-223 is prescribed. But there is the potential for this more selective treatment planning and prescription like we do with external beam radiation. Some of the challenges with radiopharmaceutical therapy include the logistics, the lack of access often to the oncology research infrastructure due to radiation precautions, the regulatory complexity, and the multidisciplinary coordination. The logistics, if the radiopharmaceuticals are given in your own department, you should be aware of the radioactive materials license, the facilities, including an isolated treatment room and bathroom and radioactive waste, the radiation safety precautions, the workflow. We have a 14-page standard operating procedure for for lutetium PSMA 617 in our department. The logistics of dosimetry and PK analysis, and again, all the documentation required to give this safely. So the logistics varies a lot between the different agents. So if it's very simple for radium-223 is outpatient treatment, 30 minutes appointment for treatment with a preloaded syringe that already is loaded with the specific dose based on the patient's weight, and minimal precautions because there's almost a pure alpha emission. So the exposure to staph is minimal. Then a little more complex is lutetium PSMA or lutetium dotatate, which has got to be in a shielded or separated room and have a separate bathroom. And we usually put down all of these sort of contamination prevention efforts with chucks and covering all the door handles in order to prevent contamination of the bathroom. It takes 2 to 3 hours per treatment for PSMA and 3 to 4 or 5 hours for lutetium dotatate because it's often given through an infusion instead of injection. And there's different infusion techniques. And for lutetium dotatate, it's longer because there's a peptide pre-infusion. Very challenging, and I'm not going to talk about this too long, would be iodine-131 MIBG for pediatrics because of the radiation protection efforts needed around iodine-131, and because of the younger patients requiring sometimes anesthesia or urinary catheterization in order to comply with radiation safety protocols. The access to the research infrastructure is related to the infusions typically can't be given in the infusion suite of the Medical Oncology Center because it's only given through authorized users in nuclear medicine and radiation oncology. So training the nurses to help with infusion and also the medical physicists or therapy techs to be able to do the quality assurance and all of the documentation required is important. The research pharmacy cannot be used. So the drug has to be routed through radiopharmacy typically, or to hot lab, and there has to be, of course, radiation safety. And then there's also regulated shipping and limited access to research phlebotomy or core lab if the specimens are going to be radioactive. So these are things to highlight in terms of trial development. The radiation review of dose to staff and patients can delay the IRB process, and then the drugs are ordered individually because of the short shelf life, because of the half-life, several weeks in advance, and difficult to cancel the treatment once it's ordered. Multidisciplinary coordination is really important for any radiopharmaceutical trials among medical oncology, nuclear medicine, and radiation oncology in particular. And these are all of the colleagues on our most recent trial that were heavily involved as the leads. And typically I communicate with the patient's primary medical oncologist prior to each cycle of treatment. And the trials can be run through our department, medical oncology or nuclear medicine. And so it can be confusing working with multiple research teams. But in conclusion, I think that radiopharmaceutical therapies really are an exciting area for future development. There's many clinical trial opportunities, especially with recent FDA approvals, and particularly with the SWOG radiation group. You may want to consider combination trials with external beam, but also for those of us who have radiopharmaceuticals through our radiation oncology departments, there's, I think we should also submit concepts for just systemic therapy combinations as well. Dosimetry, I strongly encourage. I think that there's just an amazing amount of information to be learned from doing dosimetry with each trial. And we have the potential to perform personalized precision medicine in the future. And as radiation oncologists, I think we should advocate for that. And while the trials can be challenging and require significant prep and multidisciplinary collaboration, they are highly rewarding and exciting to perform. So with that, I will stop sharing screen.
Thanks, Dr. Keys, for that excellent keynote on a really important and emerging area, I think, for radiation oncology, both the society and at the clinical trials level. I think we have a couple minutes for questions. Okay, Dr. Park is getting up.
Hi there, thanks very much for speaking about that topic today. I'm just wondering how you all got started in having this in your department rather than in nuclear medicine.
Well, it's both actually, and there's a long and ongoing history. I think that probably the most important point in our Hopkins story was when radium was approved. Our department started giving it, and that was before I was in the department. But Dr. DeWeese led the effort in making that available through radiation oncology, and the disease site leaders developed the practice and many clinical trials in that area. And then I did a postdoc in nuclear medicine with Marty Pomper, and when I joined the faculty, continued collaboration with him on the PSMA therapies, both preclinical and clinical research. So we are hoping to actually have a dual line service for PSMA 617 now that it's FDA approved. But it's an area that can be very difficult to negotiate politically, but I think is an area ripe for collaboration with nuclear medicine.
Any other questions? All right, thank you, Dr. Keys, for that wonderful presentation, and we look forward to hearing about clinical trial submissions and concepts from this group, and also obviously from you and your research team. Thank you.
Thanks for having me.
All right, can everybody online see the screen?
Yes, we can.
Great. So the next up, we're going to have a developing study by Dr. Amini. Dr. Amini. Brought my notepad. Great. So you can.
People have good feedback.
You can use that.
So thank you for letting me spend some time to talk about this concept. Got to present it yesterday at the Lung Group 2 with thanks to Dr. Daly, and got some good feedback. But this is an area that I think many of us are very passionate about. When people ask me what's my area of interest in lung, I say stage 4, and people are like, what's wrong with you? But I think most people in this group and virtual know that this is a really exciting area for us, and I think we can play a huge role. We already are, but I think we have a bigger role if we keep pursuing it. And I know our medical oncologists have great systemic therapies, and my argument is as their systemic therapies get better, we play a bigger role in the local ablative therapy. So the concept I'm presenting is this idea of a randomized phase 3 trial on SBRT for oligoprogressive disease. And my focus is lung cancer, so that's the area that I was focusing this on, but of course this can be applied to other histologies as well. I won't go too much into the background since this is a radiation group, but the idea of oligoprogression, most of our data is coming out in the oligometastatic. So upfront oligometastatic disease, induced oligometastatic disease where they're on systemic therapy and have a few sites. The area I think is a very exciting and clinically applicable area. I mean, half my practice is basically in the oligoprogressive. Are these patients that are on something systemic for a year, 2 years maybe a little less, and now they're progressing in a few sites of disease. Normally, standard of care would still say, go on to the next line of therapy, but the argument with radiation, I think you all know this, is why not do something ablative and keep them on that current line of therapy? Because we all know if we can maximize how long they're on that line of therapy, that should hopefully translate to overall survival. So that's the area that we're focusing on, the oligoprogressive patients. There's a few great studies already. Dr. Tsai presented her amazing work at Sloan Kettering at this recent Astro, and excitingly enough, lung seemed to have a PFS benefit. This was a randomized trial, phase 2, looking at oligoprogressive patients either going on the next line of systemic therapy as they're progressing or getting consolidated radiation to a few sites of disease. Breast cancer didn't pan out for a number of reasons, but I think this is, and it still might, but being a lung cancer person, I was excited to see that there's potential for the non-small cell lung cancer patients. So this is the trial proposal. The idea here is that these are oligoprogressive, 1 to 5 sites, non-small cell lung cancer, no oncogenic mutations that can be targetable, and we can discuss that. Tried to keep it a clean study, though I always get excited and want to include everything, but then at the end, those are easier to accrue, but then leave open-ended questions and a mix of the population. The primary should be controlled, but if it's not, that can be considered an oligoprogressive site, and all these sites have to be amenable to SBRT. And they get randomized with these stratification factors. Some of the feedback yesterday was to also include systemic therapy, so you could potentially stratify by IO chemo versus IO alone, and then go either to SBRT to all the active sites of disease, and then continuing on that same line of therapy, or systemic therapy alone, which would be the next line of systemic therapy that the medical oncologist wants. The primary endpoint I chose selfishly because it's a smaller number, but I think realistically the better primary endpoint would be overall survival. But right now I selected progression-free survival. Other endpoints would be time to next systemic therapy. I think that's a really important question. The rate of salvage SBRT, and I'll talk about that in a slide. Overall survival, which again, going based on great feedback yesterday, I'm going to do some power calculations with our statistician to see how feasible that is, but I think obviously that would be the best primary endpoint for this. Quality of life, overall toxicity I think is important. We all know that SBRT is great, but it does have some toxicity, especially when you're treating multiple sites. And then localness and control rates. Also, exploratory endpoints. I think this is key. I am not smart enough to deal with the exploratory endpoints, but there are a lot of smart people in this room, virtual and elsewhere, that can help. But I think, we all know clinically, I have patients where I'm crazy and all of a sudden we're treating 4 to 5 sites of SBRT because they don't have any other options, and then they come back 6 months, 9 months later, and they're still on that systemic therapy. And then I have the patient that I SBRT'd one site, 3 months later they have 20 mets. So clearly it's not just a number game. We all know that. There's more to it. So using circulating tumor DNA to potentially look at outcomes, see if that's a measurable way to do this. Also looking at immunohistochemical stainings, which is my part under there. I think that's really what's going to make this a lot more novel than just a study of saying 1 to 5 mets, you get SBRT or not, and there's a benefit. I think we need to learn how to better select. This is my sort of option in this. So if you go on the SBRT arm, what happens if you progress more? Well, my idea still is this, keep them going on that same systemic therapy. So this is sort of built into that. So if they get SBRT and they progress on the next image, on the next 3-month scan, could you still stay with SBRT? And so, we can always debate about this, but I said, well, if there's more than 5 sites of progression on the next CT, then maybe not. If you can't do more treatment, say you already treated 3 spots in the lung and you just don't feel comfortable or it's not amenable, then, and you can't give an ablative dose, then maybe that shouldn't be one to continue. Or if the medical oncologist says, look, I've had enough. So this is just kind of built in for the salvage part that I think is also important. Sorry, the slide is small, wording is small, but I'll kind of summarize this. You can bring it up. You have a question now?
Yeah, I think why are they, of all things, progression-free survival instead of overall survival?
Right.
It's got to be better to have less tumor than more tumor, so that if you kill the biggest ones, people are probably going to live longer even if they do get progression. So I would fight for the overall survival. I mean, who looks at progression-free survival?
Yeah,
it's almost been debunked, right?
Yeah.
Well, but why would
Unless
they choose it as their main endpoint? It's not, we're not trying to figure out whether the chemo worked, we're trying to figure out whether the radiation worked.
Yeah, and that's a great point. And that came up yesterday too. Dr. Daly suggested it and others, and I think that's something I'm going to go back and look at. I'd argue medical oncologists change their management based on PFS, but they will also not listen to radiation oncologists unless we prove an OS. So I think we need an OS for that.
And
I hope there's no medical oncologists in the room. But.
And the biomarkers are going to be key. I mean, the biomarkers are going to be key.
I agree.
Right.
So I'll try to wrap it up in these last few slides. I kind of already summarized the inclusion criteria, 1 to 5 sites of progression. I know some may say that, why are you including up to 4 or 5? The other question is why you're including 1. I think many of us in this room would say, if you have 1 site, I'd just SBRT it. But I think it's still a question we should answer. And so if we end up enrolling more people that have 2 to 3 and not 1, I think that's fine. I just didn't want to make 1 site of progression exclusion criteria. They all have to be amenable. Doses of radiation we can always discuss as hopefully this moves forward. I gave a range of 24 to 30 in 3 fractions and then 30 to 50 in 5 fractions based on OARs, but that's something we can hash out later on. Primary, if it's progressing, it'd be considered a site and treated. Brain mets I think should be allowed. And should be treated, and I didn't count that as a site of oligoprogression, but you could. And then maximum 3 lesions per organ site. There's good data now that's maybe more than that would be pushing it. And then ECOG 2 or less. And for the, I think it's always good to incorporate other ablative therapies like surgery. Like I'm not a big fan of cryoablation, but modalities like that, and so I wanted to keep that open-ended. I think surgery is a good option sometimes for patients, as long as 1 site's amenable to SBRT. I think patients can get surgery too. We talked about the endpoints already, and then, sorry, this was a duplicate slide. So I talked with our statistician a little bit. It's kind of hard to do power calculations with this because there's not a lot of data in the oligoprogression, but based on what there was, this is kind of what we came up with. A superiority design, anywhere from 200 to 350 patients, But I think, one of the important things is to go back and look at overall survival, which I think is a far better endpoint. I just can't wait to see the numbers, which might not be more. Sometimes I've been fooled. And I think, that, as they say, if you're going to do a study, do it right so you don't have to come back or question it. So those are my slides. Sorry to go quickly, but I'm open to comments, questions. This is sort of what we talked about. Is this a reasonable trial design? I think the group yesterday felt it was. Overall survival was considered the better endpoint. One side of progression, I think that's a great point, whether those should be included, but I thought it'd be reasonable, and if people, and I understand. I would still enroll, but I know some people would say, look, I'm just going to treat them off trial, and that's fine too, I think, but it needs to be answered. Whether to include oncogenic driver mutations, there was some great points made. I think the point that came up yesterday is those patients that are on an EGFR inhibitor progress and are on another systemic therapy, those potentially could get enrolled, and I think that's great. And then I've learned the hard way with cooperative groups is make sure it works with other trials. This is a different population. It's kind of on the outback side, so it doesn't conflict with the current oligometastatic trial with NRG, our lung map trial in Cigna. This is all kind of when they fail on those studies, they could get enrolled on this. So at least as of now, and I know I'm sure people are thinking of this, I don't see any conflicting studies with this so much, but it's always a risk. All right, thank you. Sorry. Please.
So I think this is a fantastic proposal. I think it's a really valuable question, not just the de novo oligometastatic, but this progression I think is such a valuable question to address. This is reminiscent of a study that's moving forward, I think, with NRG and SWOG in the colorectal space, the Erasure trial, and they're allowing any ablative therapy, whether it's surgery, RFA, microwave, or radiation. Why not liberalize it and just have any ablative therapy?
Yeah, and I agree. I put that on the last, and sorry if I wasn't clear. You could definitely, I think as long as you have one site of that you treat with SBRT, I think it's very reasonable to have ablation, surgery as options. Yeah, definitely agree. Thank you.
And I agree as well. Do have at least one site radiated. The data on getting abscopal effect with surgery is really bad.
Right. And there are lesions. You have
Nestlinger had a paper on that for prostate.
Mm-hmm. Yeah, no, I agree.
And then just regarding the biomarkers from the breast group, they're doing a lot of extracellular vesicle work, which is really fascinating. And make sure you talk with them, like other people, about what you collect, because even if you don't know what you're going to do with it, like plasma and imaging, it's really valuable.
Yeah.
So build it in.
Thank you. I agree.
One thing we didn't talk about yesterday, which touches on, I think, what you said, the importance of balancing having a nice homogeneous group, but maximizing enrollment, is the definition of oligoprogression, particularly in terms of, is there some time that, I think there's a big difference between the patient who starts, let's say, chemo IO, a few sites are stable, and one site's, versus the patient who's, like you originally described, sort of 6 months stable on disease, or everything's melting away, and one site's progressing. And those are probably going to have two very different expected outcomes. So just, I don't know what the right answer is, but paying attention in terms of the definition if you want to get a more homogeneous group.
Yeah, I agree with that, and we'll definitely have to hash that out, because I think the timing of it matters, the definition of it matters. So, thank you. Great, thank you, everybody. Thank you.
So I'm going to ask the traditional question, who would open this study and enthusiastically accrue? Right, so now you can go back to the lung committee and say, listen, everybody in radiation loves this study. All right, so Dr. Park, let me see any chats. Does anybody online have a question? All right, so we are second of two. Dr. Park.
All right, thanks very much for letting me speak today about this subject that I'm very interested in, and I think we have some new data in this area in stage 3 non-small cell lung cancer that we need to approach now with a new trial. How do I use this? Just with the, there we go, some disclosures. For stage 3, and for stage 3A N2 non-small cell lung cancer, we know there's many different options here for our patients, and it's very confusing for a lot of our patients as well as for us as physicians. Do we go with surgery first, followed by chemotherapy, or chemo-RT, or chemo-IO? Do we go with chemo, then surgery, or chemo-RT, then surgery, or chemo-IO, then surgery? There's also, you can also go with chemo-RT alone, or chemo-RT plus immunotherapy afterwards, or even now being investigated chemo-RT and immunotherapy together. There's even more combinations if you have an oncogene-driven non-small cell lung cancer as well. So how do you decide? Just to go over this, the INT-0139 study, which had its origins here in SWOG from Kathy Albanin and the group here, looked at stage 3A non-small cell lung cancer with N2 disease, looked at chemo-RT followed by surgery versus chemo-RT alone. And found overall that progression-free survival, looks like the font's not all appearing here great, but the improved progression-free survival in the chemo-RT and surgery arm overall, but not overall survival. But when you looked at post-hoc analysis, there was there looked like there may be some improved overall survival with the surgery arm, but not in the, if the patients got lobectomies, but not if they got pneumonectomies. So in the SAC study, and there's others as well that looked at chemo-RT versus chemo in the neoadjuvant setting, and found not really much benefit in the RT setting. This is not something we use as often anymore with chemo-RT followed by surgery, but still has its role in some patients. Now, Checkmate 816 data is what just is about to come out now. This led to FDA approval already, and is going to be presented tomorrow at AACR in New Orleans. This was a study of stage 1B, at least had to be at least 4 centimeters or greater, or stage 2 or 3A. This trial looked at neoadjuvant chemo-IO versus neoadjuvant chemo prior to surgery. And the IO used here was Nivo. They stratified here by stage, 1B to 2 versus 3A, as well as by PD-L1 status and sex. Here's all we know so far from the FDA approval data. And again, we'll hopefully learn more tomorrow at AACR. But the efficacy overall was quite good with the chemo-IO group compared to chemo, and then the median overall survival the median event-free survival was 31.6 months versus 20 months. Pathological, the PCR rate here at the time of surgery was 24% versus 2.2%. So very promising in relation to neoadjuvant chemo alone. But now, if we look at, of course, specific study, which I don't have to tell to this group, I don't have to tell too much about, but just because not everyone practices lung cancer, I'll describe it a little bit, which is this one looked at chemo-RT with or without consolidated durvalumab afterwards. And here's it's a kind of a small print here, but you can see the differences in the top progression-free survival and the bottom overall survival up to 5 years out, showing that there really was a huge improvement in both PFS and OS up to 5 years at this point. And actually the best numbers we've seen in really any trial so far at the 5-year data point, which is very exciting. And this is really an unresectable patients as well. So this is not really in a resectable population, yet we still saw such good outcomes here with Pacific. Now, ongoing trials in non-small cell lung cancer as well. And in this setting, there's a Keylink study that's looking at consolidated durva versus doing actually RT plus chemo plus pembro concurrently, and then also adding on olaparib as well, PARP inhibitor. There's also EA5181 as well as Pacific 2 that are looking at concurrent immunotherapy along with chemo-RT. Then there's also ongoing phase 1 and 2 trials in this space, but here's without chemo. So for performance status of 2, there's a trial here at SWOG, as well as for better performance status patients, but who have PD-L1 high. Then there's LU004 through NRG. So that's what we're up against here. But overall, what do we make of this here? It's really hard to do cross-trial comparisons, but in general, they all have different populations, and it's really hard to know what to make of this. So ultimately, what do we think we know? I'd say that we think that chemo-RT then surgery, if it's lobectomy, might be better than chemo-RT alone. If it's used, and then if you're using chemo-RT, not necessarily much better than neoadjuvant chemo alone. In the neoadjuvant setting, chemo-IO probably better than chemo alone. So that's probably our new standard at this point if you're taking the people going to surgery. But now in unresectable stage 3, if we're not using surgery at all and just doing chemo-RT and immunotherapy, is that the way to go? So what we really don't know is which of these arms is the best one, and that's and really also are all stage 3A and 2 patients the same either. Especially with, there's some patients with more nodal stations involved or more bulky nodes as well that are all considered in the same group here in the same stage. But are these patients all the same? So potential trial concepts here. So here's the trial that I think got the most, we presented this at the surgical subcommittee yesterday as well as the RT subcommittee. And this was the one that got the most traction, which was just really straight up chemo-nivo and then lobectomy versus chemo-RT and durva. So this is, it'll be basically the Checkmate 816 trial protocol versus Pacific. So the idea would be to enroll clinical stage 3A and 2. Actually, and there was some talk about expanding it to 3Bs as well, because I think one issue with the Checkmate trial is that people are looking a little bit beyond 3A even, or at least beyond what we normally take people to surgery for, and saying, well, if we get really good pathological complete response rates, or at least good, then maybe we could, even really expand the indications for what's considered resectable. You can stratify by stage here. You can stratify by number of positive stations, by the bulk of the largest nodes, as well as by PDL1. And the hypothesis would be, here, the way I like to frame it is as a phase 3 superiority trial, where the hypothesis would be that chemo-nivo, then lobectomy is superior to chemo-RT than durva for stage 3 and 2 patients. I think this may be a little bit controversial given that in the resectable setting right now, I think the overall standard of care may be the surgical arm, but in my mind, I think in this N2 setting, the surgeons in a way have the burden of proof to show that really that's actually necessary to use surgery in this setting, and that it really is helpful. We could also design this as a non-inferiority trial, but that would be a much larger sample as well. We haven't run any numbers yet because this is all very preliminary. But the primary endpoint, we can consider overall survival or progression-free survival, similar to Pacific. And then secondary endpoints looking at toxicity, quality of life, and other correlates, like we talked about in the last study. So some advantages are that this is a very straightforward comparison. Both are current standards of care, so we wouldn't even need the drug companies to provide drug. And then Pacific would be new in the resectable setting, but you would expect that it'll be at least as good, if not better, than what we've seen in the unresectable setting. For the patients who, but the issue is that there are many variables here. There's different drugs, there's different local therapy, different sequencing as well. So it might be difficult to interpret afterwards. And there's nothing hugely novel about either of these arms at this point either. So we talked about the possible designs here. I've also been talking to Brad Perez about this idea of a phase 2R. There's a way you could look at it where you kind of pick the winner with a smaller sample size if it's something that looks overall fairly similar. And then if similar survival, then you can weigh toxicity and quality of life a bit more as well. But I think in an ideal world, we'd be able to pull together a phase 3 on this subject. These are some notes from the the Surgical and Radiation Committee. Just things to point out. We don't think we'll have too much competition here because the other trials that are ongoing are mostly in the unresectable setting. So we're hoping that, and then the ECOG study is about halfway through accruing and hopefully about 2 years from being finished accruing. We have to work out a lot of the fine details regarding inclusion criteria. Do we even include N3 patients? I mean, do we go all stage 3 patients who are considered resectable? How do you define resectable? Is it really by each institution and each patient? That seemed to be what we all came to mostly as consensus, was kind of allow the patients, the groups to decide themselves who's considered resectable. And then, how would crossover work? There's some patients who may get the chemo IO, and there may even be, some kind of pseudo progression, and maybe patients, maybe the surgeons don't want to take them to the OR anymore. Could you cross them over to the other arm? I'm just going to show briefly some alternate schemas as well, because I'm interested in this idea of chemo-nivo up front for everybody, and what if we do that, and then you randomize to either surgery or some kind of RT-based treatment. I think we would actually learn a lot about that regimen just through the crossover effect, right? Just for patients who should be getting or randomized to surgery and not getting it, we would learn more about that group. We don't really quite know yet how those people do it because it hasn't been a regimen that's been studied yet. But we have, proposed here, something that would take longer, which is to really look at the unresectable patients first, compare specific to this idea of doing neoadjuvant chemo IO followed by radiation, and then take the winner of that and then randomize. But this probably would take a long time. So I'm not, the groups weren't as enthusiastic about this idea. But I think we could learn a lot about this kind of arm, this other arm, through just the crossover. And that's basically all I got. Thank you.
So, question about the different immunotherapies that
Yes.
you're planning to use here. So the both of these are FDA approved, so you wouldn't need to get any company to sponsor this.
Exactly.
And you just got insurance approval
That's exactly
for
right.
everything. You wouldn't have to go through CTEP even.
I think that's probably the case, yeah.
And then I guess my other question about the alternate schema that you have, is there any data about the mixing of these different immunotherapies in the same patient, neoadjuvant Nivo and then adjuvant Durva?
I don't think so yet. I don't think we know that yet. I think it's an important question. And that's the reason I think the group felt not very comfortable using this as an approach, because we just don't really know anything about that. But a few things in that. Do you still need chemo afterwards if you already got chemo as part of neoadjuvant therapy? Do you need Durva afterwards if you already got Nivo? Is that even helpful, or is it even harmful? So I think we would probably need more safety data on that before we really did that. But if patients are being crossed over and they couldn't get surgery, then you can kind of do whatever you want at that point. And I'm not sure what the answer would be then. The other question here is, after the chemo nivo and lobectomy, there's actually a study now ongoing that's looking at, do you add more immunotherapy afterwards as consolidation to kind of be similar more to arm 2, which has overall 12 months of Durva. And I think I'll just leave that up to the investigator at that point, depending on what data comes out in the meantime regarding that topic.
Interesting, thank you.
So we have a question from Brad Perez online. Go ahead, Brad.
Yeah, hi, can you guys hear me?
Yep.
So first of all, yeah, I heard this talk yesterday from Henry in the lung radiation group meeting, and this is something that we had been chatting about with Janelle Gray, who's the new chair of the lung overall committee as well. And I think that there is a lot of enthusiasm. Just getting back to the kind of trial design and kind of how to try to frame this. I think that it's really tough to declare a standard arm here, with these two approaches, especially if you're really aiming to evaluate the N2 patients specifically that fall into that potentially resectable category. And so, that's why I think potentially one way to circumvent that is just to say that you're going to select some potential margin of practical equivalence that could exist. And I mentioned that pick the winner design in our earlier discussions, and I know that's typically associated with a phase 2 design, but really, I think that how tight you say that equivalence margin maybe should be will dictate the number of patients that should be enrolled. And so, I don't know, I think maybe we could talk to the statisticians and see if there might even be a larger phase study that could be considered. And the only point is that, if the outcome is that there is no significant or no, real difference between the two arms in terms of efficacy that we see at the end, I would just favor having some a priori, guidelines written into how kind of a superior regimen would be decided on, based on toxicity, quality of life, some of these other factors. I don't think it necessarily limits you to a phase 2 design, though.
Good point. That's a very good point too. I think that's going to be the next step, is figuring out exactly the numbers that would be required for superiority versus versus non-inferiority study with a reasonable margin. I think in an ideal world we do a non-inferiority. I agree.
But even in that case, like, how would you know which which arm needs to be shown as non-inferior, and
Right.
so I think that's the challenge, like kind of how you approach this from the front end of which approach is standard. There's going to be a lot of feelings about how that should go, and ultimately that will affect the final interpretation of the study as well. If there's really no significant difference and we define some superior arm up front, then then that could be seen as the winner, basically.
That's a good point too. Yeah, I think the other thing, what I'm expecting to see in a way is that it's not that different from each other. And if that's the case, do we find that some of these stratification factors are really helpful in determining which are the patients who benefit more from surgery, which ones are the ones who do better with radiation? I think we'll hopefully learn that.
I think all those things definitely should be written in ahead of time as well, kind of however you want to slice and dice the 3A and 3B, maybe even 3C groups, into pre-planned analyses so that we can really look at all that in an a priori fashion after the data is collected.
Perfect, thank you.
I'm kind of worried that you're asking too many questions. I just don't think there's going to be enough data there, and there'll be a lot of hand waving. The reason that so many treatments are not clearly one better than the other is they're all just as bad, right? I mean, wishing it wasn't the case, but that's the way it is. And so when you do a randomized study, the original concept for doing randomized studies was not to look for hair differences between the arms. It was to look for home runs. And I might instead say, listen, we know that the radiation isn't adding that much because there's some toxicity probably, right? And if we want to maybe use a different doublet, triplet, you might try something like a PARP inhibitor or something that's supposed to work with radiation, as opposed to having two different immune therapies. Because at the end, they're going to say which immune therapy was the better one. I mean, maybe the reason the group did worse is their Valimab was worse or something. So you're just going to run into trouble with that many questions in one study. I think you need to clean up the arms a little bit.
So I'm concerned about this. I mean, I think this is a great question to ask, but how to ask it and also how to frame it so like it actually might get priority and move forward. So I'm going to throw something totally different out, and I'm not a lung person, so bear with me.
Sure.
So these are two standards of care, correct?
Correct.
I mean, you could take it, putting my NCORE hat on, could you not ask a patient-reported outcome or toxicity as your primary endpoint, do a smaller trial, and have lots of great correlative science on it to try to tease out who might benefit from each of those approaches? And I bet you could get some funding from either the Hope Foundation or the NCI to assist with that question, and would probably get higher priority. You would have to approach it to the NCORE once you kind of work with everyone to figure it out. But I think that one might move forward in a more expedited fashion.
That's really helpful, thank you.
Yeah, that's, I'm going to give a second to that. If you have a biomarker endpoint like ctDNA or circulating tumor cells, you only need less than 100 patients, in which case CTEP almost always approves it. And it might even be more important to do that study, because if doctors see less ctDNA, they'll go, I want to use that one. It won't even be an outcome. I mean, it'll almost act like a real randomized study in terms of impact.
Interesting. Thank you.
And then I just had one question that I was a little confused. Again, not a lung person, but it sounded as though that what you were thinking is if that you're marginally resectable and then you got to the point where resection wasn't possible, they were going to go into the RT arm. Aren't you going to bias the arm? Are you going to keep them? I mean, that's a flaw. You can't, you're going to, so would you keep an intention to treat or?
Exactly.
I don't know that that's necessarily going to correct it. I mean, I've run into this in my own study design, and they basically were like, don't do that.
To not use IAT, you mean, or to not do the
Well, it's
crossover?
just, you're going to, so the RT arm is going to have more advanced disease.
Right.
And even though you have an intention to treat, you're not necessarily going to correct it. And you're going to do all this work. and end up with a result that people are like, well,
Yeah.
you know, they're not exactly.
Or they hadn't responded well to the neoadjuvant chemo. Yeah,
Right.
you're
So I
biasing
think-
against that. So
I
yeah,
feel like
I
you
think
should almost,
IIT is,
if you were doing
yeah.
the alternate schema where they got whatever up front,
Mhm.
you almost have to, the people who are not eligible for surgery just have to kind of go into a separate analysis and keep your primary if you're going to
Right.
directly compare them, because they're not going to be they're not going to be
Yeah.
the same cohorts.
Yeah, yeah. I think overall we'd have to keep it IIT and just
Well,
if
no,
they-
not
if they-
IIT, but like if you are no longer surgically resectable, you become a different analysis almost, and you
I
keep
see,
the
okay.
people that are still resectable
Okay. I
randomized
see
for
what
the
you're saying.
actual primary analysis, because you don't want to include people who are going to be so much worse, and they're automatically going in the RTR.
Yeah, yeah.
So.
Okay, thanks so much. So really terrific. So I'm going to ask, I'm not going to ask about whether anyone will enroll because there's multiple designs, but does everyone think this is an important area for investigation? Essentially, yeah, so great. All right. This is the hopefully the most efficient hour in medicine. We're going to take a landscape of all of the clinical trials out there. And great. So is Dr. Jaxi on?
Yep, I am.
Terrific. So you just tell me to advance the slides and I will.
Excellent. Well, we'll get started then. So I'm really happy to be able to update you on the progress within the breast committee. Next slide, please. We have one currently open SWOG trial. Next slide, please. It's SWOG 1706, which is a randomized trial of olaparib with radiation therapy or radiation therapy alone for inflammatory breast cancer. So all these patients get the standard approach of neoadjuvant chemotherapy. They get a modified radical mastectomy, and they either get their post-mastectomy radiation alone or together with a radiosensitizing dose of olaparib. Next slide, please. And so here you can see the schema, and we are now actually up to 100. So as of the end of March, we actually got 3 more patients. So we're at 1/3 of the full accrual so far. Really appreciate those who've been putting patients on trial. We did have a period of sort of slow accrual over this winter. And so we've been reaching out to those who are at sites that have had really good and unexpectedly high accrual to try to see if there's any tips for identifying patients who are interested in this trial. My own experience has been that if I have an inflammatory breast cancer patient, they tend to be very interested in a trial because they've been scared all along the way that this is very aggressive disease. And so they like the idea of a randomized trial that allows them to try a radiosensitizing agent that shouldn't be all that much more toxic in combination with radiation, given the very, very low dose that we're using. So my thoughts are that just these patients are quite uncommon, and we have to remember to offer them the trial. So I hope people there will continue to raise the awareness of the trial and accrue as much as possible. Next slide, please. We have 2 really exciting trials in development. One is led by Eileen Connolly, and you guys have heard about her really visionary trial for IORT for DCIS after breast-conserving therapy. It's her way of turning a gift from her surgeon into a gift for the field, actually, and being able to actually understand this in more detail. And then one led by Corey Spears, which you guys have also heard about, really exciting, building on his preclinical work, combining CDK4/6 inhibition with radiation therapy for ER-positive locally advanced breast cancer. So next slide, I'll just show you the schema that has been updated for the revised S2003, which is Eileen's concept. And this is going through DCP, and she's been very nimble at adjusting the study design. And so I'll just give you a moment here to see how this trial is currently set up. So I know you guys have seen various iterations of this in the past, and this is where it is. Hats off to Eileen for doing extraordinary work to get all of the preliminary work to credential sites and be able to figure out who could really participate in this. This was an extraordinary amount of work, and I hope that this time it will go through. Next slide. And this is the diagram from Corey of the phase 1 trial. So as you'll recall, Corey wants to proceed with the phase 2 through SWOG. He is now funded by Novartis to develop the phase 1 with just 3 centers. And so those 3 centers will be U of M and a community site in West Michigan, as well as 1 additional site from SWOG. And so it's very, very important for anyone who's interested in being that 1 additional SWOG site. Please take a screenshot or take a picture of the screen right now, or, Google Corey to find Corey Spears at, so he's C Spears at med.umich.edu. Contact him if you're interested in hearing more about what would be involved in being the third site PI. Next slide, please. We also have 2 championed trials in other groups. Those include the CCTD, the Canadian MA39 trial of regional nodal radiation, and the NRGBR007 trial, the DEBRA trial of omission of radiation in biologically favorable patients, which is being championed by Dean Shumway. Next slide, please. CCTG, Taylor RT, has had a number of amendments there. And so you can see here now not only are macromets, but also micromets permitted, and T3N0 disease. So it used to be 1 to 3 macromets. Now you can also have any number of micromets, or you can have T3N0 disease. In addition, now you can have an oncotype up to 25. So previously it was 18. It's been increased to 25 based on some retrospective analysis of the NSABP B28 trial. The lower age limit has been lowered from 40 to 35. So you can see that there. And there's a little bit more of a permissive window after completion of chemotherapy or after surgery. So instead of having to be on the trial within 12 weeks of surgery or 8 weeks of chemo, you now have an extra 4 weeks for each of those. Next slide. This is the DEBRA trial. So this is omission of radiation therapy for patients who have biologically favorable disease as measured by the Oncotype DX recurrence score. They're over 50 years of age, T1N0 disease, and they are randomized to endocrine therapy alone or radiation therapy and then endocrine therapy. And so they're just opening up. Really important for us all to try to accrue to this trial. It is awfully hard to sell randomization to treatment versus no treatment. Taylor RT, at least the PMRT patients on Taylor RT are randomized to treatment or no treatment, but at least the BCS patients on Taylor RT, the MA39 trial that I just showed you, are radiation to the breast only versus radiation to the regional nodes, which is, I think, at least in my experience, an easier sell than radiation or not. So I think it's going to take everyone contributing to really make this trial design successful. And as we know in breast cancer, we have a history of being able to pull off this trial design because patients are so incredibly committed to helping us learn for the future. Next slide, please. A couple of other things that we've been working on. There is a secondary analysis of radiation therapy use and local regional outcomes by recurrence score and radiotherapy receipt in S1007 that we just submitted to ASTRO and included everyone who'd been attending breast committee meetings in the most recent years. We also are likely to move forward with looking at the genomic signatures that Corey has developed in S8814 and looking at local regional outcomes in the not too distant future. Congratulations to him for his JAM Oncology publication recently, and so hopefully we'll be able to do that, looking specifically at the local regional contracts soon. And then there's a couple of concepts that are being envisioned in the breast committee that are being led also by people who are radiation oncologists, including potentially an oligometastasis concept that Shane Steckline will be leading, and perhaps a novel approach towards repeat conservative management after local regional recurrence of breast cancer. And those are very early in the development process. And if you're interested, please do speak up, because I think there's room to get involved there. And I think that's all I had for slides. Yep.
Dr. Jaxi is always setting the bar very high. Thank you. Dr. Wang.
Hey, yeah, thank you for that. So the CNS, SWOG CNS group is actually a working group. We have been in the process of forming into a committee, and that's led really by my colleague, Dr. Memi Alawali at Miami Cancer Institute. So a lot of these trials that we have currently are trials in other groups, but also some of the concepts we presented in the last meeting, as well as the very productive meeting yesterday at our SWOG CNS working group. Next slide, please. So this is currently an ongoing Alliance phase 3 trial. This is the A071801 trial, randomizing patients who have up to 4 brain metastases, one of which has to undergo a gross total resection, and they're randomized to either single fraction radiosurgery as well as single fraction radiosurgery to the unresected metastases, or to fractionated stereotactic radiosurgery, and that would also apply for the unresected brain mets. And the primary endpoint here is really time to surgical bed recurrence. As some of you know, Some studies have been published from Paul Brown that's shown that single fraction radiosurgery control rates are about 70% 1 year. And some of the more other single institutional studies and as well as some prospective studies have shown some improved local control rates with fractional radiosurgery. So this study has accrued very well. Apologies, accrual is actually in the high 160 or 170s as a last update from CTSU. So projected this will hopefully close by the summertime. And so there'll be more updates at the next SWOG meeting. Next slide, please. So this is NRG BN009. This is led by Dr. Vinay Gandhi, as well as Dr. Michael Chan. This is a phase 3 trial for salvage, either whole brain or hippocampal avoidance whole brain radiotherapy with radiosurgery, or just salvage radiosurgery at the first or second distant brain relapse after upfront radiosurgery. And patients have to have a brain metastasis velocity of 4 or more METs per year. So some of the studies have been published from Wake Forest by Dr. Chan has shown higher brain metastasis velocity was associated with worse neurocognitive death. And that's what the concept has led to this phase 3 trial. So patients have to have more than 4 brain metastasis velocity will be eligible for this kind of study to be randomized to either an SRS hippocampal avoidance approach or just radiosurgery alone. There have been some difficulties accruing patients on this study, and some of that concerns from other site investigators have been addressed. So hopefully this will pick up with accrual and more updates to follow at the next SWOG meeting. Next slide, please. So this is NRG BN007. This is maybe less radiation oncology specific, but it's also one of the new glioblastoma phase 3 trials that have looked at unmethylated MGMT promoter methylation status. Patients are randomized to either getting standard radiation temozolomide followed by adjuvant temozolomide, or just with concurrent ipi-nivolumab without temozolomide. And for the radiation therapy arm, for the temozolomide arm, Optune is in fact allowed. This is accrued fairly well. It's accrued about 140 patients out of 400. So more updates to follow with this trial. Next slide, please. So this is the Alliance A071702 trial. This is led by colleagues at WashU, Mayo, as well as at DFCI. Next slide, please. So this is really for patients that have a recurrent glioblastoma and can have either the first or second recurrence. So they can either receive second salvage line therapy and then undergo surgical resection. And the specimens are sent to Foundation One to assess for tumor mutational burden. And in particular, those patients that have a high tumor mutational burden, which is greater than 20 or more, would then receive nivolumab, ipilimumab, and the dosing is as listed by there. And this is the current trial schema. For us, it's accrued very well. Next slide, please. So I've kind of briefly, we're not going to talk about all the concept trials as per discussed yesterday, because some of the concepts were fairly new, but this is a study that I have presented before at the SWOG-CNS working group. This is phase 2 study of atezolizumab and tocilizumab with radiotherapy in patients with newly diagnosed MGMT, unmethylated glioblastoma. Next slide, please. So really with, I'm sorry that was cut off, but with a lot of the feedback that I've received from the CNS committee in the last 2 SWOG meetings, we've really kind of tailored the study a little bit more, including keeping this as a phase 2 study for patients who are going to get maximal safe surgery, followed by radiation therapy with atezolizumab and tocilizumab, and the adjuvant atezotocilizumab. Again, this is limited for unmethylated MGMT patients, we've presented this concept to Genentech and have received drug funding support for this study. More next steps to follow with respect to meetings with CTEP and also from our CNS SWOG group. Next slide, please. So, and just to add, in terms of the last prior concept, that was also specifically for unmethylated MGMT newly diagnosed glioblastoma. This is a concept from Manmeet Ahluwalia with Yasmin and Rupesh from Miami Cancer Institute using TCR 102 and temozolomide in patients refractory as well as first-line newly diagnosed glioblastoma. Next slide, please. So this concept is really primarily for MGMT promoter methylation glioblastoma. This is a phase 1/2 study of TRC-102. For those that aren't familiar, this is a DNA-based excision repair inhibitor. And in their recurrent glioblastoma study, they found that this drug was particularly sensitive for GBM patients that have MGMT promoter methylation. And this has led to this phase 1/2 concept of using TCR and temozolomide in combination with focal radiation therapy. And that's, thank you. Next slide, please. That's it.
Great, terrific. Thank you, Dr. Wang. Dr. Horowitz. Yeah. Tony, we have a question.
Yes.
Hey, Tony, have you talked with the Dr. Albane's clinical trial planning for either of those concepts? Only because she had mentioned very early this morning that there was one CNS with her. Are you aware of that, or?
I'm not, I'm afraid. I'm trying to set up a meeting with Mandy next test, but yes.
All right, homework for me, thanks.
Great.
All right, Tony's always a tough act to follow. I'll keep my discussion brief for the GI concepts. There are no active radiation trials right now in the SWOG GI group, but we have several that we are championing and also several that are in development. We'll talk about some of the ones that we're championing. The NRG GI-006 phase 3 randomized trial of protons versus photons for treatment of esophageal cancer. This is Steve Lin's trial. This is accruing pretty well. They're at almost a third of their accrual goal. And the primary endpoint on this is overall survival, as well as a composite cardiopulmonary toxicity endpoint that they've published on previously. So these are co-primary endpoints. The second one, the EA2183 trial, a phase 3 gastroesophageal study looking at oligometastatic disease and the role for consolidated radiation. This study has been on hold for a long time while an amendment was going through adding on immunotherapy, which is now approved in the first-line setting for metastatic disease. This trial just reopened, and so they've only accrued 14 subjects to date. And this is an especially important trial, again, very similar to some of the ones that we've been discussing in this group. So I'd encourage people to open this and to enroll. I'm the champion on this study, so open, enroll. The NRG GI-003 study looking at protons versus photons for HCC, sort of the successor trial to the 1112, which closed early. This is accrued pretty well, actually, 60 out of 167 subjects to date. And again, this is powered for overall survival. So I think that this is, again, an important question to address. And then in the anal cancer sphere, we have the EA2182, which is looking at decreasing the dose of chemotherapy and radiation for patients with early stage T1 or small T2 N0 anal cancers, looking at disease-free survival and quality of life outcomes for these patients. Jim Murphy's the champion for this. And again, this is an important study to try to look at quality of life endpoints for these patients. So I'm sorry? Yes.
I'm just interested because it's a non-inferior study going toward interpretation.
That's correct.
Let's keep going because there's like 7 more.
Yeah, it's a complicated statistical design that they have for this. There are a lot of endpoints going. Very briefly, we are working on an anal cancer high-risk protocol since EA2165 has completed, and there are no high-risk anal cancer protocols that are active in the US right now, looking at neoadjuvant immunotherapy. And this is a 3-arm study that we've been developing with support from the GI committee as well as the rectoanal task force. And we've had this favorably reviewed by CTEP. And after more discussion with all the parties involved, the third arm is going to be replacing placebo with just a strict standard of care approach for chemoradiation, which I think will help us identify an arm that we may be able to move forward into a larger phase 3 trial, looking at the question of neoadjuvant atezolizumab or atezolizumab combined with the TIGIT inhibitor, tiragolumab. So with that, I'd like to open it up for any questions.
Great. Thank you, Dr. Horowitz. Outstanding. All right, we're just going to keep going because we do have a fair number of these. So this is the GU update. We have the biggest update is Dr. Dan Hamstra, who joined the Radiation Oncology GU group. So these are relevant publication updates. There's a late-breaking abstract to ASCO from Everest, which is a renal cell, followed by surgery study. I'm just going to move on quickly. S1802, this is the metastatic prostate with a local therapy. Please do try to open this study if you haven't opened it at your center. It's an important question. SWOG 1806 is accruing very nicely. This is bladder preservation. The key thing for us is we need to start thinking about the successor study to this. So it's kind of hard to do if you don't know which arm wins, but even with that caveat, if you have an interest in bladder cancer, please try to think about what the next study would be, because this is an important space. S1931, the probe study is open. It's accruing slowly. This is immunotherapy-based combination therapy with or without cytoreductive nephrectomy. S2011 is a randomized study that is not accruing very well. It's accrued 0, but it did just open. So if you do have an interest in muscle-invasive urothelial carcinoma, not necessarily just in the bladder, but anywhere, please consider opening this study. S1937 is eribulin with or without Gemzar for metastatic urothelial carcinoma, refractory to or ineligible to immunotherapy. This is also accruing very, very slowly. So if you do have an interest in urothelial carcinoma outside of the bladder, probably more a med-onc question, I guess. And then we also did have earlier in the meeting a SWOG GU symposium trying to prime the entire group into thinking about radiation for oligometastatic disease. I encourage all of you to think about this and try and come up with studies. No, there's tons of white papers that have already come, not society papers, but that's a great idea. Thank you.
All right, thank you very much. For lung group here, we have 4 trials ongoing right now. And then we have some SWOG endorsed trials as well. I'll go through briefly. So the Maverick trial 1827 is phase 3 study looking at MRI surveillance plus minus PCI for small cell lung cancer, both limited stage and extensive stage small cell. So please consider for all those patients. It's a little bit slow right now in accrual, around 85 patients right now, but hopefully picking up soon. LU005 is actually accrued very, very quickly, which I'll talk about in a bit, but that actually is not enrolling with this. So I think once that's closed, hopefully Maverick will pick up as well. SWOG 1914 study. This is accruing about almost at 100 patients now. This is looking at SBRT with or without immunotherapy in the stage 1 non-small cell lung cancer space. So this is the one arm has SBRT alone, and then the other one has immunotherapy before SBRT, during and afterwards, for 6 months total. This one is for stage 2 to 3 non-small cell lung cancer who have PS of 2. So this is accrued about 14 out of 47 patients so far, stage 2 to 3. And the idea here is to give hypofractionated radiation, 60 gray and 15 fractions, followed by either, and then afterwards they get immunotherapy. Here's superior sulcus tumor, the S1934 study. Sorry, it's cut off up top. This one has just opened. It actually was closed again and then reopened just now. So they have not enrolled yet. This is a very rare subset of patients who have superior sulcus tumors that are resectable. But the idea here is to give atezolizumab plus chemo followed by surgery. It's actually chemo, radiation, and atezolizumab versus chemo and radiation as neoadjuvant therapy. So even though this is a very rare tumor. It's really important to open this at as many sites as possible. And it's the only way that we're going to be able to complete this study. So those are the 4 that we have open at SWOG. Just briefly, the other SWOG endorsed studies, the LU002 is looking at maintenance systemic therapy plus minus using local therapy with SBRT plus minus surgery. So this one is accruing overall pretty well. They're on a pre-specified interim analysis and have already accrued about half the patients, actually more than half the patients so far. And they now allow for immune therapy as well for systemic therapy. So that's really picked up ever since that amendment. LU005 I referred to earlier, so this one is limited stage small cell, so it's chemo-RT versus chemo-RT and immunotherapy. This is actually almost 2 years ahead of schedule, so accruing extremely well. 449 patients out of a planned 506, so probably in the next couple months this will be closed down. We were going to open this and then just it accrued so fast we're not even going to have it open on time. So this has good news for this trial, but that's why Maverick will be good to use in that setting afterwards for the limited stage patients and extensive stage patients. LU007, the Raptor study, is looking at atezolizumab plus, so if you're getting chemo and IO for extensive stage small cell, do the consolidated RT afterwards. It doesn't just have to be to the thorax, it could be up to 5 sites in total. This has been accruing pretty slowly, only 27 so far over the past year and a half, but hopefully picking up over time. And then this one is the ECOG study I referred to earlier in my talk, which was concurrent chemo-RT with immune therapy as well. And the control arm here is a Pacific regimen. So to see if we should be moving immunotherapy earlier in the course. This one's accrued about 317 patients out of 660, so about halfway through as well. This is the LINE study that just opened very recently as well. This one is looking at advanced non-small cell lung cancer, PD-L1 negative. So then they're either getting IO or chemo IO, but you can, on one arm they get randomized to SBRT to 8 grade times 3 fractions. So in summary, we have trials in both SWOG as well as endorsed studies for early stage non-small cell, locally advanced non-small cell, metastatic non-small cell, in both oligometastatic and the PD-L1 negative setting, and then small cell, both limited stage and extensive stage. So it's overall a pretty good portfolio we have. But the one gap we have right now is stage 3. That doesn't fall on either borderline performance status or superior sulcus. Thanks.
Okay, Dr. Constantine, take it away. Is Dr. Constantine on?
Hi, I'm sorry, I was muted. Sorry I'm not there with you all. It's been a sort of a difficult week because we have simultaneous children's oncology group meetings, so couldn't travel. Anyway, so our lymphoma committee activities that relate to radiation are the following, and Chul and Chelsea are also work with me in this group. So the biggest trial and the most important is S1826. This is the phase 2 randomized study of Nivo and BV plus AVD. And it's a very fast accruer. Next slide. So this is the schema. So we have newly diagnosed advanced stage Hodgkin lymphoma patients, and they're treated with AVD with either Nivo or BV. And they only get radiation if they have a Deauville 4 or 5 score at completion of therapy. And next slide. And you can see that already 797 patients have been accrued out of the targeted 987. So it's actually going to be totally filled way prior to the target date. And next slide. And the concept with respect to radiation is only to give treatment to areas that are Deauville 5 or 4 at completion of therapy, and there are very strict criteria, which were actually in the last slide. I'm not going to spend any time going into details on this. And next slide. But here in brief, they have to have a residual nodal mass more than 2.5 centimeters, and or extranodal disease more than 1 centimeter. that's PET avid. And the radiation dose is 30 gray to the residual anatomic volume with an additional 6 gray to the PET avid site. And this can be done with SIB. So out of all those patients that have been entered onto this study, I think there have been about 5 who have actually got radiation. And there are 2 reasons for that. Number one, the institution needs to declare up front as to whether their patient's going to be eligible for radiation. And secondly, the chemotherapy is doing a remarkably good job of converting patients into Deauville 1, 2, or 3 disease. And I'll just a quick interesting update from our COG meetings. The last study that we had that compared BV AVD with our historic COG chemotherapy approach, which is AVBE-PC, which has always been which is very good. The BV arm is way better. So, and that study is, I mean, some of the analyses are still coming in, but in any event, the immunobiologics are really making a big impact on this disease. Next slide. This is a study which will be opening sometime between June and the end of the year. This is for early stage patients. It is COG led, but includes SWOG, Alliance, and ECOG. Patients start with ABVD, and if they're PET negative, they don't get radiation. They get BV and Nivo, and if they're PET positive, they do get radiation. So once this is open, I can discuss it in somewhat greater detail, but essentially it's going to be similar in design with respect to radiation to the last trial I just reviewed, 30 gray plus a boost to the PET avid sites at completion of therapy. Next slide. So yeah, well, here essentially the clear view of this particular study. But if those RER means they're rapid responders, and there are criteria for that with respect to the PET, and then the slow responders are the ones that will be randomized to BIACOP versus BV Nivo, and then they'll get radiation. Next slide. Another study that will be opening is the non-Hodgkin's lymphoma, a phase 3 trial looking at Nivo up front in primary mediastinal B-cell lymphomas. And again, this is COG led. The patients essentially get R-CHOP with or without radiation, or EPOCH-R. And not to go into the details of these chemotherapeutic regimens, you're probably familiar with them, but if maybe not. And a similar concept in terms of the radiation doses, about 30 gray with boost depending on the avidity at completion of therapy. Next slide. And we submitted a report, and what it looks at is whether or not patients with limited stage large B-cell lymphoma who have extranodal presentations do better with radiation. I mean, it's one of the areas in this disease where radiation has apparently been very helpful. And there was a study out of Memorial which showed that radiation actually benefited those patients with extranodal disease at diagnosis, but in the review of the SWOG studies, that was not seen. There was really, whether patients got radiation or not, their outcomes were very similar in the SWOG studies. It was submitted, and it's going to be resubmitted. And that's it, very briefly. Oh, yeah.
Thanks, Dr. Constantine. That was terrific. Dr. Wuthrick?
Yeah, thank you. Can you hear me okay?
Yes.
All right, I'm going to share screen then. Oh, no, you have it. Okay. So just there are 3 currently open studies in the melanoma group looking at various aspects of immunotherapy in melanoma. There's an active open adjuvant study. There's an active open neoadjuvant for stage 3 disease. And then there's a study that's looking at the role of immunotherapy in patients with desmoplastic melanoma. And then across the NCTN, there's also the Merkle cell carcinoma trial that's run by ECOG. It's a randomized study that's very simple. It randomizes patients with stage 2 and 3 Merkle cell carcinoma to either observation after surgery and radiation or pembrolizumab. And so that's a 500 patient study that's about around half accrued. So if your institution sees a Merkle cell carcinoma patient here or there and doesn't have that study open, there's still a lot of time to contribute. I wanted to talk a little bit, and I know we don't have a ton of time left for this, about a secondary analysis that we're doing of SWOG 1404. And I'm going to go through it pretty briefly in the interest of time, and just kind of give you a very brief overview. And then maybe, I don't know, James, maybe we can, if there's some time on a future call, maybe I'll go in a little bit more detail on some of this information.
Yeah, we can put you on a working group call.
Yeah, thanks. So just real briefly, as everybody probably knows, adjuvant radiation therapy remains controversial in stage 3 melanoma. There were several large single center retrospective reviews in the 90s and 2000s that showed a regional recurrence and regional and recurrence-free survival benefit. And then most of us know about the TROG 02.01 study, which randomized macroscopic node-positive patients to RT versus observation. But there's a risk of increasing some lymphedema. There's a question about how much it really impacts recurrence-free survival and overall survival. And all of this data that we had collected was in the pre-immunotherapy era. Next slide. So SWOG 1404 is potentially an opportunity to look at the effect of radiation therapy, because it was a study that looks at pembrolizumab versus a control arm of older immunotherapy drugs, and looks at 1 year post-surgery. They had drug for 1 year post-surgery, and adjuvant radiation therapy on this study was left to the discretion of the treating physicians. So we are able to sort of look at the hypothesis of whether in the immunotherapy era, adjuvant radiation therapy improves any of the important metrics. Next slide. So this is a giant study, 1,300 patients. We put together a database of which 1,239 patients had complete radiation therapy and pathologic data necessary for analysis. Next slide. And we looked, at all of the sort of markers on the path report that would predict somebody's risk of regional recurrence, as well as other markers in the tumor like PD-L1 status and BRAF mutation status, and where they're on the control or study arm in this analysis. And we place people into the high risk or standard risk group based on the TROG criteria that have been used in the past. Next slide. Next slide. So in this 1,300 patient study, 136 patients received radiation therapy at their institution. Now, remember that there are patients that are early stage 3 patients who we wouldn't have recommended, who wouldn't have thought were in a high risk group, were part of this population as well. So in total, about 11% of the patients had radiation therapy, and those that had radiation therapy skewed a little bit more, as you'd expect, more advanced disease. So stage 3C, they had more likely to have macroscopic lymph nodes, more likely to have ulceration, and more likely to have a large number of lymph nodes involved. Next slide. What we found is that when you just look at the whole group, not accounting for any kind of high risk features or not, the time to regional recurrence was much lower among those who had a course of radiation therapy compared to those who did not. For all comers, there's a 9% regional recurrence risk at 4 years versus a 1% regional recurrence risk at 4 years with radiation therapy. Next slide. If you just look at the high risk people, and these are broken down by what arm the patient was on, whether they were on the anti-PD-1 arm or not, you can see that there's about a 12% 4-year risk among patients who, regional recurrence risk among those who did not receive radiation therapy, and about a 2% 4-year risk among those that did. Next slide. Recurrence-free survival is not particularly different with looking at the whole cohort. Next slide. Or when it's broken down, just looking at the high risk group and broken down by arm. Although you can see that there's a trend towards significant improvement in those, a trend towards a better curve in those patients who received both anti-PD-1 therapy and radiation therapy. That's the black line in this graph. And the hazard ratio there is 1.54, p-value 0.085. Next slide. Go ahead, next slide. There, we did not see a difference in distant metastasis-free survival. Interestingly, the only patients who had a regional failure on trial, on this analysis, were those that received a radiation therapy regimen other than 30 Gray and 5 fractions or 48 Gray and 20 fractions. I don't know if that means anything or not, but it's interesting. Next slide. Here's another way to look at the data, which is to sort of see the cumulative incidence at 1 year, 2 year, 3 year, and 4 year of those patients who had radiation therapy or did not. And the lower is the relapse-free survival Kaplan-Meier estimates at 1, 2, 3, and 4 years. Next slide. So to summarize, for high-risk patients, the time to regional recurrence was longer in those who received radiation therapy, regardless of their study arm or PD-L1 status. We also actually saw that for the whole group in general. There's no significant difference based on like anatomic site, because we split this out by which nodal basin was irradiated or their BRAF mutation status or PD-L1 status. And we thought that it was interesting that among the patients treated with pembrolizumab on this trial, there was a trend towards recurrence-free survival benefit. Next slide. So there's a lot to discuss and to talk about in this paper or in this analysis, but it's what I would say the first good look at what the regional recurrence rate is in the modern era with modern surgery, with modern adjuvant immunotherapy. We have a much lower overall recurrence risk than what was listed in TROG 02.01 and a lower regional recurrence risk than in the EORTC experience, which I've put here on this table. There's a lot of limitations of an unplanned secondary analysis, but we're pretty excited about this data. And there's no getting around the fact that there's a very low regional recurrence risk among patients who get a completion lymph node dissection and radiation therapy, only 2% at 4 years, even among very high risk patients. So sorry, that probably ran a little long. And we can talk more about this data if you wanted it at a different time, but thanks for allowing me to present some of it.
Great, thanks, Dr. Wetherick. We'll definitely get you on for a working group meeting. So Dr. Cook, are you on?
Hi.
Great.
Okay, so since there's no like active radiation trials in either of these committees, I just wanted to take a minute to sort of give you guys the flavor of what's going on in them and perhaps stimulate some ideas for collaboration. So just as a reminder, which I think is helpful, the Cancer Survivorship Committee has a number of priorities: preventing the long-term effects of treatment, reduction in comorbidity to improve cancer outcomes, reduction in health disparities, and then they also have a focus on mobile health and tech in care delivery. There was a talk from a doctor from the NIH who sort of talked about the areas that they want to focus on. So some of these have to do with, like areas where they're interested in funding, but also just where the SWOG committee wants to start some trials as well. And some of them are pretty interesting. For example, there's difficulties when cancer survivors present to rural healthcare facilities. For example, someone presenting to the ED and they might have gotten their chemoradiation at an academic site, and then the ED doc doesn't really exactly know what to do with these side effects. And so there's an interest in education from that standpoint. There's a NIH misinformation initiative, which is something that cancer survivors are uniquely susceptible to. So that's misinformation from friends and family, from the internet, things like that. So trying to cut back on that in cancer survivors. There's an interest in financial hardship. And then there's a notice of special interest for disparities affecting healthcare utilization in childhood cancer survivors. Next slide. Just briefly, some of the active studies, mostly not super relevant to the radiation crowd, but just to give you an idea of what they're doing. There's a study, SWOG 1501, looking at carvedilol to prevent the cardiotoxic effects of anti-HER2 therapy in breast cancer patients. 2204 is perioperative physical activity in older adults with lung cancer. And then this 2013, which is a cross between this committee and the Symptom Control and Quality of Life Committee, which is basically just looking at immune checkpoint inhibitor toxicity. They emphasized a special interest in the metastatic population. And, we had that nice presentation of a oligoprogression concept earlier. And so there could be room for collaboration, survivorship issues in the oligoprogressive population, people living longer with metastatic disease. There's also overlap with their, focus on disparities, access to care. A lot of people in rural areas may not have access to even SBRT. And then, what are some of the long-term toxicities from SBRT if people are living longer after having had it for oligometastatic disease? Misinformation is something that I'm sure you all have to fight in clinic all the time. And so, if there's a concept related to reducing misinformation and radiation therapy, I'm sure they'd be amenable. So all the folks on this committee seem really eager to collaborate with us. I think they're just sort of, waiting for some ideas. So next slide. This one is a little bit, this committee was even less related to radiation stuff. In fact, they have their priority overall is to understand the mechanisms of symptoms better and develop new methods to reduce patient suffering. But they emphasize that their clinical focus are these things which are basically, med-onc related. So they're very focused on neuropathy, immunotherapy toxicity, endocrine therapy toxicity, and then treatment-induced cognitive impairment. They have a few active studies there, immune-enhancing nutrition for patients undergoing cystectomy for bladder cancer. There's a peripheral neuropathy limb cryocompression study. And then there's SWOG 2010, which is active symptom monitoring in young women with breast cancer, which is sort of like a, app-based check-in thing where they put in their symptoms and then get contacted by their healthcare team if they are having a lot of symptoms. So I didn't necessarily have great ideas for radiation collaboration there, but I'm sure they'd be amenable. So thanks.
Great, thanks, Dr. Cook. And then Dr. Connolly is going to say a few words of wisdom.
Yeah, so I actually didn't make slides because I anticipated no time. So, and Dr. Jaxie already presented my concept, which is hopefully going to go back to the executive committee and go back to DCP in May. Cancer care delivery actually mostly focuses on tools for decision-making as well as financial toxicity. I do think there's opportunities if you have an idea regarding radiation that you could come to cancer care delivery, or the prevention committee is primarily, DCIS actually fits in it, which is why my study is there. They do a lot of biomarkers for disease recurrence. So there's a testicular cancer trial that's open. There's also image biomarkers for early prediction of recurrence. So, I mean, again, there are potential opportunities for radiation focuses. So that's it. We're done.
That was perfect. Any last words, Dr. Kachnik, from the executive?
I think we've dwindled down now.
All right.
But thanks, everybody, and take the lunch on your way out for snacks.
All right, thanks. And with that, we'll close. Thank you. Yeah, everyone thank Dr. Kachnik for the lunch.